सब लोग अपना वीडियो प्लीज ऑन कर लेंगे एंड माइक अपना म्यूट रखेंगे. We have 3 presentations lined up today, one patient journey and one caregiver journey. Followed by that, we will have support group meetings. ये presentation के बाद आप सबके जो भी questions हैं, आप सब पूछ सकते हैं एक एक करके अपने hand raise के option से. And we are starting the meeting now. So, Dr. Sameer, can we start?
Yeah. So I'll present and then later on you can introduce ma'am and.
Right.
I'll just share my screen.
Sure. So we invite the first speaker today, Dr. Sameer Rastogi, who is going to give a talk today on desmoid tumors and treatment options available in it.
Yeah, can you see my screen?
Yes, we can see the screen.
Yeah. So I'll be happy to have comments in this comment box. So I'll discuss about desmoid tumors and what are the treatment options in these rare tumors. Am I audible? Everything is my voice clear?
Yes, Dr. Smith.
Yeah. So fibromatosis or desmoid type fibromatosis is extremely rare disease. And I'm really happy to discuss about this disease because in normal conferences or usually it is so rare that people just don't talk about it. So it typically happens in young adults around 20 to 30s. And this is the time when people are going for their independent living. And though it's look like benign, apparently it seems to be innocuous or benign disease. However, it might cause severe pain, deformity, contractures, and a lot of time people struggle with anxiety and depression. It happens mostly in age group of 15 to 60 years, and while peak is 30 years, usually girls and ladies are more commonly affected than males. There is something called FAP, familial adenomatous polyposis, and it might develop as a part of this syndrome. And in this syndrome, there is also happening like colorectal cancer also happens. So apparently in this syndrome, desmoid is second most common cause of mortality other than colonic cancer. So what is the site distribution of these benign tumors? So it usually happens in extremities. Majority of them happen in extremities, as you can see. However, they might happen in abdominal wall or inside abdomen. So around 36% happen in abdomen, and some of them might also happen in neck and face area as well. However, if it is related to syndrome in which patient has colonic cancer or some other cancers, then it is usually localized to abdomen. So I just keep it simple and keep it plain. Regarding molecular biology, there is something called beta-catenin mutation that plays a role in this cancer. Along with that, there is something called APC mutation, and there is something called WNT pathway. So I'll not elaborate in this. So the pathology of desmoid tumor is very challenging. And I'm sure many of the patients have got wrong pathology. They have been misdiagnosed outside just to get diagnosed as desmoid tumor in names. And this can be really troublesome and stressful for them because many times they are diagnosed as sarcoma, soft tissue sarcoma, nodular fasciitis, and malignant peripheral nerve sheath tumor, benign nerve sheath tumor. So the hallmark of this tumor diagnosis is nuclear accumulation of beta-catenin. This is on immunohistochemistry, and almost 90% harbors a mutation called beta-catenin gene mutation. So this is how this brown stain looks like. This is beta-catenin immunohistochemistry. And recently, something has come up regarding the diagnosis and the course of desmoid tumors is that we should get catenin B mutation or beta-catenin mutation done. So 90% of them will have beta-catenin mutation. Those people who are wild type, they might be harboring APC mutation. And beta-catenin mutation, there are multiple types of beta-catenin mutation. And it also has implication on prognosis because some mutations type S45, they are poor prognosis. Some like P41A, they are like good prognosis. So these are the current guidelines by European group. And as we can see, they give strong recommendation for mutation analysis. So this is a new change that has happened in last few years. And why this has happened? Because maybe in future this might have implication on treatment as well. And right, if it is wild type, then APC can be diagnosed also for prognosis. So the pathology of desmoid tumor should be done in an expert center by an expert pathologist, and beta catenin IHC is almost mandatory, which is present in 90% of cases, and mutation testing, if possible, should be done. What are the treatment options? So this is a very important part, because a lot of patients have gone ahead with surgery outside, even 8 surgeries, 7 surgeries, but it doesn't remit with surgery, and the problem gets more complicated. So regarding surgery, till 2010, around a decade back, surgery used to be the first treatment, and it also radiation was a part of treatment. However, in the current times, surgery is no more standard in desmoid type fibromatosis, and it's in universal guidelines. But there is a kind of desmoid tumor in which surgery might be attempted. This is abdominal wall desmoid if there's small tumors, but not more than once, because if it has recurred after surgery, then probably it should not be it should be avoided. So another, as you can see that for if the desmoid tumor is elsewhere other than abdominal wall and it's not responding to medical therapy or observation, then systemic therapy or medical therapy should be tried. So this is how the flow chart goes. So diagnosis, which is done by an expert pathologist. Frontline approach is active surveillance. That means to do nothing. The more you fiddle with this tumor, the more it is going to increase. And also many of the patients, either this disease stabilizes or regresses on its own, which is very unique for any tumor or any cancer. In case this disease progresses, if it is abdominal wall and the tumor is small, then surgery might be done. However, if this is intra-abdominal, mesenteric, pelvic, or retroperitoneal, then primary management should be medical therapy. And I'm sure there are few patients who just want to be disease free. And out of desperation, they go ahead with surgery, even second surgery, even third surgery. But that should be refrained from. Desperation doesn't mean that we should delve into something which is not recommended. Again, if it is extremity, it should be medical management. Head and neck, it should be medical management. So why surgery is not done in desmoid tumors? Because the risk of local recurrence is extremely high. In fact, after second surgery, the chances are that 90% time this tumor will recur. And usually the tumor comes up with a more aggression. So regarding this wait and watch approach, some patients are usually on wait and watch approach, because it has been seen that 5% to 20% of patients will have regression spontaneously, because probably this is hormone driven. With time, it might decrease on its own. So let's see how it goes. So this is a data from 2 institutes, and as you can see, this is the time on x-axis and ratio to initial size on y-axis. As the time goes on, the tumors which are apparently growing, they just stabilize, and with more and more time, almost all the tumors stabilize except 1 or 2. And this is same with primary tumors, this is same with recurrent tumor. Barring 1 or 2 patients, almost everyone will have stable disease. So regarding medical management, initially tamoxifen and NSAIDs, that are celecoxib or such tablets, used to be the treatment of choice. However, we have realized soon that there is no clear cut benefit of using these regimens. They are low cost, limited toxicity, but they don't even cause hardly any response. And as you can see, the response rate varies from 8 to 10%. That's it. That means only 8 to 10% of people who are taking this might feel reduction in these tumors. Regarding again, it's more out of reimbursement that these therapies were being tried rather than any scientific rationale. Imatinib, another drug, oral drug, the response rate is again dismal, 6% only. So right now the standard of care across the world is sorafenib, and it should be taken almost 400 mg once a day. But if patient don't tolerate, which is very often the case, the dose can be decreased. And as you can see this graph, that means at almost 2 years, 80% of patients don't progress, and almost 30% of patients will have decrease. in the tumor size. It takes around 10 to 12 months for a tumor to respond. That means patience is very necessary in this tumor. If patient doesn't respond on tyrosine kinase inhibitor or these oral drugs, then we have chemotherapies which are indicated, but not surgery again. So the chemotherapies are vinblastine methotrexate, which is less toxic chemotherapy, and almost 40% will benefit the the uh, the benefit. And again, there is another chemotherapy called anthracyclines or doxorubicin, and the response rate of doxorubicin is higher than vinblastine methotrexate, but it might be incrementally more toxic. So the guidelines suggest that we should start with less toxic chemotherapy first and then more toxic later. However, if the site is like neck or retroperitoneum or mesenteric intra-abdominal, which is life-threatening, then doxorubicin can be given upfront only. There is another drug, oral drug like pazopanib, which is as good as chemotherapy, in fact, better than this. So right now we are just facing the problem because of the India, this disease is dealing with identity crisis. And as you can see, there are few drugs which are not even available in India. There is no trial going on in India right now. So oral vinorelbine is a very promising option. However, it's not available in India. Gamma secretase inhibitor, they are not FDA approved. However, trials are not going on. We are trying that AIMS becomes site for this drug in current future. And we in AIMS are trying to do more and more of research in these tumors. And recently we compared the patient reported outcomes in desmoid tumors. We have almost 150 and 160 patients right now. And we found that 40% of patients have anxiety, 50% of people deal with depression, and pain is prominent complaint in 70% of this. So, and the stress and the quality of life in this disease might be as bad as cancers. And we are also running a sorafenib discontinuation study in which we have started enrolling, in which we are analyzing the amount of time sorafenib should be given. And because there are few reports which suggest that if you give sorafenib for 1 year, there might be chances that this doesn't grow back. Thank you. Thanks a lot. So my take home message would be that beta catenin mutation and ISC should be done. Wait and watch policy is for less aggressive disease, and surgery should not be done again and again. In extremity sorafenib, in extremity fibromatosis, sorafenib is a good drug. However, if it is not responding to sorafenib, then we should try chemotherapy. And hormonal therapy usually doesn't give so good results. And we need to have our Indian data soon. Thank you.
Thank you. Thank you very much, Dr. Sameer. It was a very good presentation. I'm sure it will spread awareness about desmoid tumors among all the patients and caregivers today. So thank you for giving the time in this presentation. We now invite the next speaker, Dr. Pratibha Amare. So Pratibha ma'am, we welcome you to our support group meeting today. I would like to introduce her today. So ma'am is a lab director and chief of cancer and clinical genetics, Lilac Insights. And ma'am has won many accolades. She is a postdoctorate. She has done the research work. She's a recipient of UICC. She has won Excellence Award in 2007. She won Bharat Jyoti Award and Best Citizen of India by International Publishing Housing. Ma'am has been doing wonderful work, and we are so thankful that today this meeting, Desmoid Tumor Education Program, is sponsored by Lilac Lab. We thank Lilac Lab for supporting this cause, and we welcome Pratibha ma'am to our webinar today, and we invite you for your talk today on role of beta-catenin mutation testing in desmoid tumors.
Thank you, Dr. Sameer and Ms. Rashi Kapoor, for your kind invitation to participate in this gathering. Especially, I am very happy. This is a very special event for me because I am going to present in a crowd of patients, which is a very rare event in my life. And I must say that I spent my 40 years in Tata Memorial Hospital. Apart from my scientific activities, I used to have always close interaction with the patients. And if I turn back, I really very sincerely feel that whatever success I have achieved in my life in cancer genetics activities, the credit goes not only to my staff, my students, but especially more to my patients. So with this word, I will start my lecture. I will share my screen. Am I audible?
Yes, ma'am.
Madam.
I hope everybody can see my screen. Okay. So my topic is understanding the role of CTNNB1 mutation in desmoid tumors. Now, before I start my topic, I would like to give you a very small introduction of what are the genetic changes, why genetic changes are important in cancer. Almost so far, all the studies have shown that almost more than 90% of the cancer, there are genetic changes. Now, these genetic changes do occur at different level. You must be aware of the term chromosomes. The genetic changes can occur at the chromosome level. These chromosomes are nothing but the condensed bodies of the genetic material. When the aberration occurs which leads to the loss of the chromosome copy number or gain of the chromosome copy number or structural aberration, for example, a break in the chromosome which can lead to the either deletion of the part of the chromosome or translocation of the part of that chromosome to some another chromosome. Now at gene level, now there are many, in each chromosome, there are few hundreds to thousands of genes are located. Now what happens at the gene level when the aberration occurs? Either that particular gene gets deleted, there is a duplication of the gene or the amplification of the gene. Now further coming to the DNA level, gene is composed of the double-stranded DNA structure. Now if you can see over here, the DNA level double-stranded DNA structure, there is a specific sequence of these nucleotide base pairs. If there is any change in the specific sequence of this nucleotide DNA base pair, for example, here you can see, there is a change from T to C. So this is called as a substitution of the DNA base pair. There can be insertion also DNA base pair. There can be a deletion also. So these are the changes which occur at the DNA level. These are called as the point mutations. Now, how do you detect these changes at the DNA level, point mutation? So there is a technique, which is a gold standard technique called Sanger sequencing. Sanger's technique here, in this technique, briefly I can tell you, every DNA base pair or dideoxynucleotide is labeled with a color fluorescent dye. So when you start analyzing this DNA base pair peaks, you can very easily identify the change in the base pair. As I said before that, you can see over here, by looking at the color and of course, scientifically looking at the base pair sequence, you can very easily identify change in the base sequence or the gene point mutations. Now it is very important to going before the analysis or details of the beta-catenin CTNNB1 mutation. What is the beta-catenin protein? Because CTNNB1 is the gene which encodes the beta-catenin protein. Now, what is the role of this beta-catenin in normal tissue? It has a multifunctional role. For example, the cytoplasmic beta-catenin protein, it maintains the cell type specific cell-to-cell adhesion. One second. Rashi, can you see my full screen?
Yes, ma'am.
Yeah, okay. Okay, now it is clear to me. Yeah. Yeah. So coming back to the function of the beta-catenin, that the basic function of the cytoplasmic beta-catenin is the cell maintenance of the cell type specific cell-to-cell adhesion by interaction with the alpha-catenin over here, and that is regulated by APC protein in the cytoplasm. Whereas there is another function of the beta-catenin, that is a nuclear beta-catenin, where the beta-catenin in the nucleus protein, which regulates the transcription factor gene like a MYC or the cell cycle gene like the cyclin D1 via wind signaling pathway. So in this way, knowing the function of beta-catenin, it is widely expressed in many normal tissues. It is also overexpressed in certain cancers like liver, lung, colon, ovary, and breast. But it is most commonly, almost 85% of the desmoid tumor shows the overexpression of this beta-catenin protein. Now, what is the gene which encodes this beta-catenin? It is the CTNNB1. Let us look at the CTNNB1 mutation. Now, what is the importance of the genetic studies? As Dr. Samir has already said that when the tumor biopsy goes to the pathology lab, the pathologists who diagnose the tumors, various different kinds of the tumors. However, in 1/3 of these desmoid tumors, there is a misdiagnosis. Why? Hello? Why? Because there is a dilemma, because the morphology, histopathology, which is seen under the microscopy, there is an overlapping between the desmoid tumor and the other soft tissue sarcoma malignancies like the low-grade fibromatosis sarcoma, synovial sarcoma, or the GIST. So in that case, what happens? Pathologists take the help of the immunohistochemistry, the expression of the beta-catenin protein on the tumor biopsy. But sometimes, rarely, it may happen that due to the staining artifact, the pathologist cannot certainly or with a 100% guarantee can diagnose, yes, this is the desmoid tumor and this is not the desmoid tumor. In such cases with the dilemma, 1/3 of the desmoid tumors, the CTNNB1 gene mutation by sequencing is a very specific and sensitive diagnostic test which can resolve such difficult situations. The CTNNB1 gene, which is mapped to chromosome 3p21, and most of the mutations occur in exon 3. What are these common mutation hotspots in CTNNB1 mutation in desmoid tumor? S33, S37, T41, S45. These are the common mutational hotspots in the N-terminal phosphorylated site of beta-catenin, where actually there is an interaction of the APC protein. And because of this APC protein interaction, beta-catenin gets degraded later on. Okay. However, when there is a mutation occurs in the CTNNB1 mutation, there is no more phosphorylation and there is no more degradation of the beta-catenin gene because it is mutated. APC regulation or APC control over the beta-catenin mutation regulation is lost. With the result, it leads to the altered abnormal expression of beta-catenin protein, which leads to the increased cell proliferation and enhanced immunosuppression. Now, when we talk about the desmoid tumor, as I said, 85% of the sporadic desmoid tumor, they show CTNNB1 mutation. Now, CTNNB1 mutation can be also observed in other tumors. However, what is the specialty of the CTNNB1 mutation in sporadic tumors? There are 3 common mutations which have been discovered in sporadic desmoid tumors, and these are S45F, which shows serine alteration of serine to phenylalanine, and the frequency is 30 to 40%. T41A mutation, this S45F, it is a very aggressive mutation, whereas T41A, which occurs with a frequency of 40 to 50%, which shows the change of the amino acid threonine to alanine, it is a comparatively less aggressive and shows the better prognosis. The third mutation, S45P, the frequency is very, very low, sometimes 5 to 7%, sometimes 2%. The change in the amino acid is the serine to proline. Now, most of the studies which have been focused in these two mutations in the sporadic desmoid tumors because of the frequency is very higher and the prognostic different. So S45 is very aggressive. T41A is associated with the better prognosis, less aggressive. So let us look at these two subgroups. These are the two molecular subgroups, S45F and T41A. These are the two molecular subgroups with respect to beta-catenin stabilization and also the expression of the other gene profile. The most important is anti-tumor immunity. S45F mutation is the strongest prognostic factor, which shows the local recurrence almost in 50% of the patients with more aggressive clinical course. The relapse-free survival of this mutation is poor versus T41A mutation and wild-type CTNNB1, that is a normal. S45F, as Dr. Samir has already said, that it is significantly more prevalent in extra-abdominal sites. Now, as I said, apart from these desmoid tumors, sporadic desmoid tumors with CTNNB1 mutation, which are where more common mutations are S45F, T41A, and S45P. But 20 to 25% of the other cancers, like a colon cancer, gastrointestinal, ovarian, thyroid cancer, also show CTNNB1 mutation. But what is the importance over here? They show the CTNNB1 mutation other than S45F, S45P, and T41A, which are more common in the sporadic desmoid tumors. Now, these are the survival curves. Here also you can see over here, the S45F in comparison with the T41A show a decrease in the recurrence-free survival. Now, when you try to detect the chemotherapy or radiation therapy or many other therapeutic targets on the tumor cells, what is the most major indicator? That is the apoptosis. The analysis of the apoptosis, that is the programmed cell death. Now here again, when you compare the apoptosis mechanism and effect of the apoptosis in S45F aggressive tumor versus T41A less aggressive tumor, you can see over here, there is a growth of the fibroblast. There is no apoptosis here. Whereas you can see the cell death in the T41A positive tumor cells. So here again, you can see the apoptosis measure is higher in T41A positive tumor versus S45F tumor. These are the apoptotic cells after the treatment. Now, Lilac Insight, we have developed or we have established 2 years back a program that is the CTNNB1 mutation in desmoid tumors. Of course, Dr. Samir, I give the credit to Dr. Samir because he was after me. He and with his support and with his encouragement, we developed this program in Lilac Insight. This is just to show you the example of the 2 cases. You can see over here, by application of the Sanger sequencing, we could identify this S45P, as I said, is a very, very low frequency, but we could detect this. You can see over here with the Sanger sequencing, we could detect the T substituted to C. This is another 30-year-old female T4, which is showing T41A tumor. As I said, it shows the better prognosis and it showed the substitution of A to G by Sanger sequencing. So apart from this sporadic desmoid tumor, there are hereditary desmoid tumors also. Now, what are these tumors? These tumors have the family history of gastrointestinal disease and strong family history of desmoid tumors. Now, the most common gastrointestinal or colon familial or hereditary colon cancer is the FAP, familial adenomatous polyposis, which is the autosomal inherited disease. And here, especially this FAP, when they develop the desmoid tumors, there is a germline mutation in the APC gene. That is, and the desmoid tumor further later on developed with the biallelic mutation in the second allele. Okay. Now, why you will ask me why there is what is the role of the APC mutation in this hereditary desmoid tumor? If you remember my initial talk that this beta catenin in cytoplasmic beta catenin, which is controlled by APC. So when the mutation especially occurs in the APC gene at the binding site of the beta catenin gene, there is no more degradation of beta catenin. There is an overexpression of the beta catenin, and which leads ultimately to the development of the desmoid tumor, that is a hereditary desmoid tumor in these malignancies, especially FFE syndrome. And it is associated with a very poor prognosis. In such cases, there is a strong message that genetic counseling followed by genetic testing is extremely essential to assess the cancer risk in the present generation as well as in the next generations. So novel drug therapy, I will not talk much. Dr. Samir has already focused on it. I must say that in my concluding talk that CTNNB1 mutation testing is a very sensitive testing. It serves not only as a diagnostic and prognostic marker, but many studies, many anti-cancer clinical trials, it has been used as an important biomarker to analyze the effect of the therapy, especially the effect of the tyrosine kinase inhibitor, because beta catenin is the kinase. Tyrosine kinase inhibitor, imatinib, dasatinib, recently FAT inhibitor has also been tested. And what are the important significant differences in some of the studies which have been found? That is the apoptosis and proliferation. There was a significant difference in the apoptotic measure and the proliferation assay in tumor versus normal cells, in vivo and in vitro cell line. Based upon these studies and latest studies, we have a better hope that best development of the targeted therapy in future, which will definitely overcome the recurrence rate in the desmoid tumors. Thank you for your patience hearing. I think I have finished my talk. I invite the questions if there are any more.
So we thank Dr. Amare. Thank you so much for giving this presentation. I'm sure it would have been very, very fruitful for all the patients. So as per the agenda, next is my presentation, and I'll just take a minute to share the screen. Hello, ma'am. Amre, ma'am, I think I'll just share my screen. If...
Sure.
So, good evening, everyone. I'm Rashi Kapoor from Sachin Sarcoma Society. Today, I'm going to speak on the topic role of support group in desmoid tumors. So, I would like to elaborate about Sachin Sarcoma Society. So, Sachin Sarcoma Society is a patient support group. It was formed in 2018 to help guide sarcoma patients and their caregivers. We are a group of sarcoma survivors who have formed this support group to help guide, counsel sarcoma patients. The mission of the society is to spread awareness about rare tumors like sarcomas, fibromatosis, and GIST. Our mission is to remove the fear of these rare tumors, and the support group basically believes in building companionship with patients and their caregivers. On a personal note, I'm a sarcoma survivor who was diagnosed with synovial sarcoma in 2016, and Dr. Samir has been my treating doctor. And with the help of all other sarcoma survivors and caregivers, we formed this support group to provide support to all the patients who are diagnosed with these rare tumors. So I would like to just... So I would like to share the survey that we conducted on desmoid tumor patients. So we have a support group of around 150, 160 desmoid tumor patients, and we conducted this survey, and we saw that number of females were more who had desmoid tumor patients compared to males. It was also seen that many patients, around 85% patients had undergone surgery before they were diagnosed with desmoid tumor. And in our support group, 55% patients are those who are actually taking sorafenib. So we are presenting a research which has recently been done from India by Dr. Vikas Garg and Dr. Sameer Rastogi. This presentation was presented in ASCO and it was also awarded. And it was basically on patient-reported outcomes in patient with desmoid tumor fibromatosis. The aim of this particular thing was to study the kind of the quality of life of patients, of desmoid tumor patients, and to see how much fatigue, pain, insomnia, and financial difficulties they do face during their treatment. It was also seen through this study that as compared to cancer patients, desmoid tumor patients have more anxiety, more depression. So even their quality of life gets affected. Now, this is another study which was done by Spain and bone sarcoma group, which indicates, and the link has been shared here, which indicates that along with, in order to treat these rare tumors like desmoid tumors or sarcomas or GIST, which are all rare tumors, along with the medical field, the multidisciplinary team, there is a need of patient advocacy group who can work along with the medical professionals so that they can support these patients in a better way. As a support group, we keep on organizing our counseling sessions, we keep talking to them, and we have seen that these desmoid tumors patients, they face the following challenges. So based on our interaction with them, we have observed that since this is a rare disease, patients do face a lot of challenges. There is already, some of them come with late diagnosis or misdiagnosis. Already there is lack of awareness about this disease among doctors and among patients. There are less number of specialists there in this country to treat this particular disease, and even treatment options are not known to them. So we have seen that many patients in our support group have come who have undergone surgery at the first place, which as per the presentation by Dr. Sameer and Dr. Amare, surgery is not the right option at the first place for this, for dealing with this particular disease. Now the question is what needs to be done. So a lot of things needs to be done. One thing, for the first important thing is we need to have more awareness in our country about desmoid, about among our patients. There should be more education programs for doctors. There should be more research surveys so that we can together find a cure in this. Patient registry should be done and its course of study should be studied in the Indian patients. Now, a lot of clinical trials are going on in other countries, but there is a need that these clinical trials should also come to India so that our patients can get supported because of this. Coming to the most important slide of this presentation is what patients want. As we have discussed with our Indian study, which was published in ASCO by Dr. Vikas and Dr. Sameer, which indicates that there is a lot of anxiety, depression among desmoid tumor patients. So what they want, they need a lot of psychological support. Poor and needy patients, when they come to hospital, especially AIMS or any hospital, they need a lot of help in terms of getting their scans done, in terms of getting their translocations done, like beta-catenin mutation testing, and medicines like sorafenib. So some of them are not able to even afford the cost of this medicine, and they need help in terms of arranging this medicine. They need information with regard to what is the disease, what treatment options are going to be in it, what medicine are they going to be started, are they going to face any side effects, how to deal with this particular, with these side effects. Now, I'm going to present a very interesting study here, and I have published the picture of this patient with permission from this patient. So this is a 30-year-old man who is from Jabalpur, Madhya Pradesh. He was diagnosed with desmoid in 2009. He had undergone 9 surgeries so far, and his leg was amputated. Now, since he was operated in Jabalpur, doctors over there were not aware about what is desmoid tumor, what is to be done. They operated him 9 times. it was a big emotional trauma for him because it's not easy to take these surgeries these many number of times. When he came to AIMS, he showed here to Dr. Sameer, he was started with medicine, sorafenib. Now, when he came to us and when we met him, it was such an emotional trauma for him to see the kind of surgeries that he has gone through. So as a support group, we had counseling sessions with him. And when he was put on sorafenib, we tried to help him by arranging his scans free of cost and arranging his sorafenib multiple number of times. Great thing about him is that he has shown good improvement with sorafenib, and this is a good story. How support group can help? So support group can help. Basically, our support group helps in a way by providing psychological support, by doing emotional counseling, by connecting desmoid tumor patient with a sarcoma specialist. So if any desmoid tumor patient comes, he should not go here and there. He should be connected with a sarcoma specialist. We spread awareness by distributing information sheets, by building companionship. So we have a WhatsApp group. There is a heterogeneous group where patients are there from all backgrounds. There are around 150 patients, and they all support each other, guide each other, counsel each other, and help each other to relieve their anxiety. So poor and needy patients are also helped for their scans, for their translocations. Every Sunday, we keep on organizing support group meetings to instill hope, positivity, and courage. And more social events have been conducted from time to time to celebrate life. Now I'm presenting another case study. This is a case study of a 32-year-old man who was very poor and needy. He was from Madhubani, Bihar. He was very poor. He was suspected of this condition called as FAP, with abdominal desmoid and colonic polyps. He was told to get this particular germline mutation testing done. The cost of this test was very expensive. It was around 19,000. For this patient, it was very difficult to get this particular test done. When this patient came to us as a support group, we guided him, counseled him, and understood his financial structure, that he would not be in a condition to get this particular test done. So as a support group, we tried to help him financially with the help of all the members of our support group by arranging crowdfunding for him. And this patient was helped to get this FAP test done. His report came out to be positive for FAP. Unfortunately, he could not survive during the treatment. After his demise, he was survived by his wife and his two sons aged 14 and 12 years. Since this is a hereditary disease, our support group again reached out to his wife. We counseled her emotionally, strengthened her, and told her how important it is for her sons to get the screening done and go and meet the doctor and be on regular follow-ups. In fact, for our son, who is 14 years old, we again helped that son to get that test done with the help of other members of our support group. And again, crowdfunding was done for this particular son. So as a support group, we have helped this patient emotionally, financially, and administratively. Now, work done by our support group. So as we have mentioned, we have around 125 patients in our desmoid support group from India. There are patients not only from India, but from US, Canada, Bangladesh, and Nepal. We basically provide three supports: emotional support, financial support, and administrative support. We spread awareness among patients by giving them information sheets about their desmoid tumors, about the medicine that they are taking, side effects they are going to they might face, and how to deal with them. Then newly diagnosed patients are connected with old patients so that their stress, anxiety gets relieved because of this. I'm happy to share our sister. Lakshay, if you can please mute. I'm happy to share our sister organizations and supporting organizations. So Desmoid Tumor Research Foundation, who has been doing extremely commendable work. We are trying to work. That's a wonderful organization, and we are learning so much from them. I've shared the picture of one meeting that they have done in support with Ayala Pharmaceuticals, where from India, we got the opportunity to attend this meeting, and Life Raft organization, who works for supporting GIST tumor patients. Along with this, we have support from many other organizations and many other companies who have provided us the resources to support more and more patients, like Mahajan Imaging, Diagnostic Center, Novartis, Natco Pharmaceuticals, Lilac Lab, and Nuclear Healthcare. We believe that service to humanity is service to God, and we are able to help patients with support from all the donors and all these organizations, and from guidance of Dr. Sameer. So this is our Sachin Sarcoma support group. We have shared this picture of holding hands to portray that from the time when the patient is diagnosed till the time the patient gets cured, we keep on holding their hands, we keep on supporting them, we keep on instilling hope, positivity, and courage in them, and tell them that we are there with them and they are not alone in this journey. So I'm happy to share some glimpses of some of the activities that we have been doing from time to time, especially for desmoid tumor patients. We have been doing a lot for sarcoma patients and GIST patients. Here we have shared for only desmoid tumor patients. So education program was conducted in 2018 by Dr. Sameer, where large gathering was addressed and education program was conducted. We can see this poor and needy patient, 10-year-old patient who was helped with sorafenib day before yesterday. Counseling session was organized for many patients from time to time. Even during the pandemic, the support did not stop. We kept on helping people, kept on supporting them, kept on doing teleconsultations with them, and understood their concerns, and the help was continued in their own way. From in the past, we have been doing many activities. Like we can see, this is a support group meeting where we used to invite all the doctors from AIMS and other big institutes, and patients used to be invited, and support group meetings were conducted from time to time. We can see here children are all busy because we have organized Children's Day in 2019 in India Gate. And we celebrated life by doing this program, National Cancer Survivors Day. We can see some glimpses. These are the snapshots of all the desmoid tumor support group meetings. These are desmoid tumor patients. This is the big event that we have done, Josh 2019, celebrating life to instill hope, positivity, and courage among all the patients. This is our team with guidance and mentorship from Dr. Sameer. And this is our helpline number. So we have a 24/7 helpline number where any patient from all over India or abroad, whether it's sarcoma, desmoid, or GIST, can reach out to us and can approach us. And we do believe in terms of helping them, connecting them with the doctor, understand their concerns, and supporting them in the best possible way. This would not have been possible without support. So we really thank Dr. Sameer Rastogi for his support and guidance. All my team members, without their support, this would not have been possible, and all patients and caregivers for giving us the opportunity to help them. We believe that this is just the beginning. We have to work a lot and support many patients. Thank you everyone for hearing me so patiently.